Okay, so we'll continue where we left off yesterday. Okay. Uh, Oleg, what do you think? We're talking about heel pain syndrome.
Um,
I think this was a trainer for one of our major league baseball teams.
so there's edema on the medial side, I guess.
Okay, so they're looking for stress fracture
Stress
plus
fracture,
osteomyelitis.
osteomyelitis. Okay.
They've had pain for 6 months after he had obviously the surgery here, the heel
Uh-huh.
valgus
Hmm.
osteotomy.
Hmm.
And so here we can see a lot of postoperative changes. Obviously, the osteotomy defect
I
here in the
see.
calcaneus. If we go to the sagittal images, what do you
Um,
see?
uh, again, pathological changes
Okay. And we also see a lot of diffuse bone marrow edema here in the
mhm.
calcaneus, right? And probably some soft tissue edema, maybe even a little bit of an effusion there. Uh, the history on this patient is that this was a couple of weeks into spring practice, and his heel pain was markedly increasing now that he was back active again after having the surgery. So, well, what do you think's going on here?
Maybe just uh, like just that transient edema, maybe
Which one?
transient edema.
Well, we don't know that it's transient. We
Okay.
just see the edema there, right?
Okay.
We don't know what the time course is going to be at this point.
Um, there's
So,
a
so the question is, so you basically want to know whether it's a stress fracture osteomyelitis. So do you think this is osteomyelitis, or do you think it's a traumatic bone injury?
I think traumatic.
Yeah. So uh, he did not have a fever. He ended up not being treated by antibiotics, was treated
Mhm.
by rest, and it got better and resolved. So this is just overuse, trabecular bone injury. He had disuse probably after the surgery, got back into too much activity right away, and so this was not osteomyelitis. Tayson, what do you think of this case?
All right. Roll out calcaneal fracture. I don't see an obvious fracture line through the calcaneus.
Okay. Here's the MR.
I see some perifascial edema in the proximal aspect plantar fascia. Maybe a sprain?
Here. Okay, the bone looks okay.
Yeah.
And then here are the sagittal images.
Yeah, so same thing, just some edema around the central cord of the plantar fascia.
Yeah. Well, yeah, and then you can see it involving the muscles here,
Okay.
here, and this ended up being tears, low-grade tears of the abductor hallucis and the flexor digitorum brevis muscles through
Okay.
here. So you can also get muscle tears that can produce heel pain. Okay, Robert.
So this says tender palpable mass, and there's a marker over the plantar aspect of the foot. Is there a little thickening of the plantar fascia there?
Right
Yeah.
there. Yeah.
Yeah. So there's a
Yeah.
little nodular thickening, increased signal there.
And what would you call this?
Would that be like a plantar fibroma?
Yeah, so that's a typical plantar fibroma. And this is a small one. And histologically, these are fibrous tissue, benign fibrous tissue. Uh, these may be associated with trauma and healing with partial tears, but it's not thought that all of them are traumatic in etiology. Some of them just may be metaplastic lesions within the plantar. So this is a small plantar fibroma. They can be very painful in this location. Uh, Oleg, what do you think of this case?
Um, there's again thickening in the plantar fascia, like focal thickening.
Okay.
Um, it,
So what is this?
I mean, maybe another fibroma,
Yeah.
but
So this is a larger
a larger fibroma. Okay.
fibroma in this location. Uh, John, do you want to tell us a little bit about plantar fibromatosis and plantar fibromas? Oh, did we lose John? Uh-oh, we lost John. Uh, let me check with him and see if he's coming back on. How did we lose Dr. Yagutis? Hey, John, we lost you. Are you getting back on?
I'm trying to.
Oh, okay. All right. Well, when you get back on, I'd like you to talk to us a little bit about treatment of plantar fibromatosis, okay?
About what?
Plantar fibromatosis. Plantar fibroma?
Okay.
Okay. Okay, I don't know. Somehow John got off. He's trying to get back on again. So let's go on, and then I want to come back to this and let him tell us a little bit about plantar fibroma. Tayson, what do you think of this?
Well, yeah, there's a low T1, high T2 signal mass with the split fat side. Makes me think that it's like a nerve sheath tumor, right?
Yeah, you could kind of think about that. And this basically, if it's just saying this to me, this looks like a soft tissue tumor, most likely a sarcoma. I'd be very worried about uh, a malignant disease myself on this particular patient.
Mm-hmm.
But this was removed, and this was this was benign fibromatosis, not plantar. But this is all a benign plantar mass here. So again, you can't be too cocky in making the diagnosis of masses on MR, and it's best to get tissue diagnosis for these. Okay, Robert.
All right. Looking at the medial aspect of the foot, looks like there's some edema surrounding the tendon there.
Good, right? Yeah, and this is an abductor hallucis muscle tear, right? Okay.
Um, again, the edema in the
Well, what's the history?
male with lateral pain and swelling 1 week after playing volleyball.
Okay, so what the doctor wanted to know is, does he need to do an emergency fasciotomy? That was it. That was the clinical question.
Like fasciotomy we do to like relieve like potential compartment syndrome, something
Right.
like that, right?
Yeah.
Is there some like I don't think like there is like vital artery or something there to protect like in this muscle in the
Well, if you get compartment syndrome, you
uh-huh.
can get uh, you can get uh, increased pressure, decreased perfusion,
Yeah.
and you can get a destruction of the oops, let me see here, of the muscles. Hey, John. So let's come back. John, you with us?
Can
So
you hear me okay?
yes, let me go back here.
Oh, good. For some reason, the sound went out, and you know me, I have to close up everything and go back. You said something about me talking about
Yeah.
fibromas.
Yeah, so here's a plantar fibroma. Do you want to talk to us a little bit about treatment of plantar fibroma?
Um, for the most part, the fibromas are not that uncommon. But the last thing you really want to do to them is to operate on them. One of the problems is that they have a high incidence of recurrence. And when you remove them and you take a pathological specimen, um, the pathology has a very hypercellular structure, almost looks like it's a malignancy, but obviously it's not. Uh, but it does have a very high incidence of recurrence. So to operate on these, you're taking a chance, and you have to take a lot of the plantar fascia to prevent the recurrence. That can really disable a person, and what happens is you have to wear arch supports, etc., to support the foot. Otherwise, you have chronic pain and so on.
Thank you.
Or special shoes fitted for the individual. And I've seen multiple fibromatoses in the patient. It was one of my financial advisors. He has about 3 or 4 of them, and he keeps on trucking. He refuses to have surgery,
Okay.
and both his feet have it. He's never had a biopsy. So I just tell him, buy shoes that are comfortable and do the best you can.
Okay.
So
Thank you.
it's not a malignancy, but it sure is almost like a malignancy.
Thank you.
It won't kill you, but it is sure productive of pain, and curing it is not easy.
Thank you,
So
John.
that's about all I can tell you about it.
Great. Thank you. Okay, so we're
And they
back to
are,
this.
by the way, they are painful.
Yes, right. So, Oleg, we're back here again. So the question is what's going on here, and should
So,
the surgeon do a fasciotomy?
so to me, if you concerned about like necrosis, so that this is abductor digiti minimi, the muscle.
Well, the adductor digiti minimi is this muscle.
Yeah, so it's the hallucis longus then.
All right.
No longer brevis.
So what do you see here? What are the findings?
I see the swelling of the muscle and edema.
Okay. It's enlarged.
Enlarged swell, yeah. But
And it would be nice to have the other side, but we don't have it. And we can
Yeah.
see areas of edema, especially along the fascial
Yeah.
planes inside. In here, we can clearly see that there's edema and increased volume.
Yeah.
And so this was really a strain versus rhabdomyolysis, and this turned out to be a muscle strain. They ended up not treating it with
Not
a
really.
fasciotomy, and I think the patient did fine. But compartment syndrome, I think we'll see in other parts of the body, we'll see evidence of compartment syndrome, and that can be one of the few surgical emergencies in orthopedics.
But you don't send patient to MRI to check for that, right? If it's an emergency. I mean,
Well,
it's like,
if you can get it right away,
Makes no
often
sense
you
then.
do. John, do you want to say a little bit about compartment syndrome? John, we didn't lose you, did we? John? Well, I guess we lost him. But we'll come back to compartment syndrome with another case. Okay, Robert, what do you think of this case? John, are you on mute? John, check to make sure you haven't muted your computer. Go ahead, Robert.
Yeah, so there's a fair amount of edema kind of interposed between the third and fourth metatarsals there, or yeah. So
You're the sagittal.
yes. So yeah, there's a lot of edema tracking along that muscle belly, so I'd be concerned about a strain or.
Right. So that was a interosseous muscle strain. Good. And then here's just another example and another patient of a similar muscle strain. Okay. Tayson. So let's talk a little bit about tendons. Here's the flexor tendon we see intact here. Uh, uh, this this is the second. The patient's symptoms were actually in the first, which is here. So what do you see?
I see a defect right at the metacarpal head of the
Okay.
tendon. Yeah.
So right there. Okay. And then this was actually in a dancer, and this was a partial tear of the first flexor tendon in this location from dancing. Okay. Oh,
Look, pain, ankle pain behind 1 year after motocross riding. Look like a swelling, like over the medial malleolus.
okay. Here's what the MR looks like.
Uh, Looks like a piece of bone.
What?
Piece of bone. Like looks like edema.
Well,
What is this?
actually, it's not bone. It's not calcified on the plain film.
Okay, yeah.
So, what this looks like is a really sharply defined fluid collection.
I see.
It may be hemorrhagic with
Mhm.
some blood products in the middle with
So
decreased signal
some-
intensity within the blood products.
Mhm.
Here we can see it also. And this turned out to be chronic adventitial bursopathy
Mhm.
of the bursa. So they resected the bursa and the patient did well. Okay. So let's go on to the top. John, do you want to comment?
Well, I just came back. I
You
keep
did.
losing the sound.
Where the hell have you been? We've been
Well, the sound keeps going out on me. I don't know why.
okay. Well, we can hear you now. Okay, we're going to move on here to impingement. So this is a nice article from Sarah's Law from AJR in 2003 on ankle impingement. We'll talk about lateral, anterolateral, anterior, anteromedial, medial, posteromedial, and posterior impingements. And here's some articles on that. So you can get impingement around the ankle either from the bones due to bony anomalies, abnormal ossicles, osteophytes, or you can get it just from soft tissues. And so let's start here. Let's see. Robert, are you next?
Yeah, I believe so.
Okay.
Here it looks like there's some scarring interposed between the fibula and the calcaneus there.
Yeah, but notice the shape of the calcaneus.
Yeah, yeah. It's,
And if you actually drew a line down the long axis of the tibia and a line during the long axis of the calcaneus, this is a pretty prominent angle here.
mhm.
And
Talus also.
yeah, in the talus, and this is chronic, you can see that there's the medial talus is much higher than the lateral talus, and this is a typical lateral bony impingement, and this is calcaneal valgus deformity, and can be seen in chronic posterior tibialis tendinopathy and the syndrome of adult acquired flat foot deformity, which we'll talk about later. But this is a typical lateral bony impingement, and this is, I think, the reason why that previous patient we saw had an osteotomy of the calcaneus was to correct for the bony impingement here laterally. Okay, Tayson, what do you think of this case?
All right, so looks like we have some calcaneal valgus again, and there's a narrowing of the anterolateral joint space there with hibernation of the bone and edema in the
Right.
distal.
Yeah. And you can see the marker here. This is where the pain is. A lot of chronic degenerative disease, as you're talking about here, due to chronic bony lateral impingement. And then if we go to the sagittal images, you can see that there's marked pes planus here. And that this patient actually had a previous injury of the talus. So these are lateral bony impingement. This is on a low field scanner, where again we can see this degenerative disease, the obviously bony impaction injuries with calcaneal valgus deformity and severe degenerative disease here. So these are examples of straight lateral impingement, straight medial impingement, straight anterior impingement tend to all be bony impingements, whereas the anterolateral and anteromedial tend to be soft tissue impingements. And if you actually draw the lines I was talking about earlier, the line through the long axis of the calcaneus, the long axis of the tibia, you can get an alpha angle, which we've actually talked about before here. And if it's greater than 6 degrees, that's abnormal, which is an indication of heel valgus deformity and increased risk for bony lateral impingement. Okay.
In these cases need fusion. There are no other things that you can help the patient with, but they will wind up with multiple fusions, multiple bones, depending on which ones are deformed.
Thank you.
This one here probably, I don't think talus and tibia needs to be fused, but everything else needs to be fused.
Okay, thank you.
And corrected. What you do is you do a little sculpture. That's what orthopedics is about, sculpting and carpentry.
Okay, good. Let's see, who's next? I've forgotten. Oh, look, are you next? Okay. So what's happening here? The marker shows where the pain is laterally.
So we have like prior fracture of the fibula.
Right.
So
So another cause of lateral bony impingement are actually previous fibular fractures. And here's
Shortening of that side.
shortening or just abnormal angulation
Angulation.
of it. And here we can see that there is some impingement. And so fracture is another risk factor for lateral bony impingement. Okay, Robert?
All right, so we have lateral ankle pain after trauma, and it looks like there's a lot of edema and a fracture of that lateral talus with a small fragment there.
Yeah, so we see a fragment there. We see a lot of bone edema here. This is the acute injury. This was on 12/4/2004.
Okay.
And there you can see a fragment of bone.
Mhm.
And this is a lateral process fracture. Now, the patient came back about 4 years later with persistent increasing lateral ankle pain, and this is what it looked like.
So it looks like that has now healed, but there's, abnormal anatomy there now.
Right. So it's healed with abnormal anatomy, and now we can see we have bone on bone impaction here. So this is another cause of lateral bony impingement, which has to do with prior fractures that have healed incompletely. Whereas you also can see the same kind of change on the medial side as well. But this is lateral bony impingement due to a malunion of a lateral process fracture of the talus.
It would be hard to tell unless you examine the patient which side is more painful.
Really, yeah. And we can see a lot of stresses on the bone here, and we can see the bone edema here due to abnormal stress pain.
Probably lateral.
Yeah, probably. Yeah. And the skin markers tells us where the pain is, so it is lateral, John. Okay. So you can get soft tissue injuries also as a cause of ankle impingement, typically more anteromedially and anterolaterally. And these have to do with injuries to the soft tissues where you can get tears, swelling, fibrous repair of the injuries. When you get repeat trauma, you start getting hypertrophy of the synovium and reparative tissue with fibrosis in that area. And finally, you can get a hyalinized meniscoid lesion, which is more of a hard, soft tissue mass and osteophytes, and these are well innervated and therefore are very painful. And the treatment for these is usually resection of the hypertrophied synovium. And so in Serazol's article, he shows here where you can get this anterolaterally. This is often in association with injuries to the anterior talofibular ligament, with too much motion early on in the healing phase, where instead of getting a good healing of the ligament with fibrous tissue, you start getting healing, tearing, and you get these hypertrophied synovial tissue and fibrous healing tissue, really it's more granulation tissue, which can be mass-like, have a lot of innervation in it, and be very tender. And I think this comes from his article where you can see this soft tissue kind of hyalinized mass up here. And this is just superior to marked thickening of the anterior talofibular ligament. And this is anterior lateral soft tissue impingement of the ankle. And again, the treatment for this is resection of this hypertrophied mass. There's this another example. You can see where the marker shows where the pain is. Here we can see a marked thickening of the anterior talofibular ligament. But see, in addition to that, you should have fat back here. And very commonly we will see thickening of the anterior talofibular ligament after trauma in people who don't have symptoms in this location. But most of those you'll have normal fat replacing in here. In this case, we've had granulation tissue develop. It's become thickened due to chronic repetitive trauma in this area. You have a big, quote, hyalinized mass, which is heavily innervated. And anytime you get change in motion of the bones here, you compress this mass and it irritates the nerve endings and you get pain. So this is anterior lateral soft tissue impingement. And in the coronal images, sometimes we can see this soft tissue as kind of a mass here, which is granulation tissue, which is painful in that location. In this particular case, they went in surgically, and this is what that granulation tissue looks like at arthroscopy. Then it can be removed, as we see here, and it can relieve the impingement and relieve the symptoms.
And the only problem is it can come back.
Yeah. Well, that's what keeps orthopedic surgeons in business, right, John?
Yeah, gotta pay your bills.
Okay, right. Okay, and then moving on here, we can go to straight anterior impingement. This tends to be bony impingement again, and typically it's associated with marginal osteophytes involving the anterior tibial plafond, the anterior tibia, and also osteophytes often where the capsule attaches to the distal dorsal aspect of the talus. So here's an example. We can see a lot of degenerative disease here. We can see that dorsal talar osteophyte in this location due to chronic repetitive trauma, and this patient had anterior impingement. Tayson, what do you think of this case? Now, this, by the way, is an arthrogram of the mortise joint.
All right, so dorsal to the distal talus, there's this low signal structure there, and then yeah, I guess we have another low signal structure kind of anterior just to the talar joint on the
Talk
right.
about this.
Yeah,
So what is this?
is it
What are
arthrofibrosis?
both of these? Well, let's see. This actually is an osteophyte, and there's a little bit of edema in it. If we look on the STIR sagittal images, these are STIR images. This is an arthrogram. The reason I pointed out that it's an arthrogram, and if you remember, STIR images will decrease signal based upon T1 times. So if the T1 times of fluid is similar to the T1 time of fat, it will suppress the signal intensity within the fluid. And that's what's happening here. Because this is contrast, it actually has a very short T1 time, which makes it bright on the T1 weighted images. And it turns out that the T1 time for the contrast within this joint space is very close to that of fat, and therefore it actually suppresses here.
Okay.
And then here we can see edema in the posterior malleolus as well. And this is so what can happen here then, and then if we go to the plain films, you can see that this is a big osteophyte here. And this was a Major League Baseball player. And what will commonly happen is that these people will get a lot of dorsiflexion injuries to the ankle. You'll get repetitive impaction of the dorsal aspect of the talus that produces hypertrophic bone formation in some individuals, produces an osteophyte, and then you get more readily impaction against the osteophyte rather than the dorsal aspect of the talus, and this can continue to grow, and you'll get progressive more and more restrictions of dorsiflexion and pain on dorsiflexion during sports activities. So this is anterior bony impingement. The treatment for that is to removal of the osteophyte. Okay. Oleg?
So we have like maybe like broken osteophyte. It's like so if there is a edema in the dorsal the talus.
Okay. Edema here,
and then
also edema there.
Yeah, and then there is a piece on the top.
So here we have an osteophyte here, and we have an osteophyte there.
But there is something also on the top of that joint.
Yeah, and this is fat. And
Oh, this is fat.
Subcutaneous tissue fat
okay.
here, right?
All right.
So this is a relatively common appearance of anterior impingement. We have repetitive dorsiflexion injury. In this case, we have a lot of grade 4 chondrolacia throughout the mortise joint as well. You start getting hypertrophic osteophytes, both involving the anterior tibia as well as the dorsal aspect of the distal talus. These osteophytes grow, and as they grow, you get more and more restriction of dorsiflexion, more and more trauma to the bone, more and more hypertrophic response to that trauma of the bone, and more restrictions. And this is a very common cause of anterior impingement. So that's anterior bony impingement. Moving on, here we can go to the anteromedial aspect of the ankle. This is a case where you typically have soft tissue impingement, and you can get soft tissue thickening involving the capsule here on the anteromedial aspect of the mortise joint. This typically occurs in runners, and here we can see this granulation tissue here from chronic repetitive trauma in a runner. This is well innervated, and every time he compresses this, it causes pain, and this is anterior medial impingement. Okay. And here's a case where we're getting a little bit more medially located. Here the bone is actually involved, but we also have a lot of granulation tissue within the soft tissues. This is kind of in between medial impingement, which is going to be bony impingement, and soft tissue, anteromedial impingement, which is soft tissue impingement. We have some osteophytes here, but we have a lot of granulation tissue there that's painful all through in here. So this is post-traumatic. Here, the combination of anteromedial and medial impingement. Okay, I don't know who's Robert. Are you next?
Yeah, I believe so. Here, looking at the medial malleolus and medial talus articulation, looks like there's again abnormal articulation there with some eburnation of the cartilage and
Yeah.
unnecessary.
So before we saw this on the lateral side, where you had a fracture of the lateral process of the talus, malunion producing lateral bony impingement. This is this. I said you can also see this on the medial side, and this is an example of that same process on the medial side, producing medial bony impingement due to malunion here of this old medial talar fracture. And that's a cause of medial bony impingement. Continuing around, we can go to posterior medial impingement, which again is typically a soft tissue impingement of the ankle. And here we can see thickened soft tissue here posterior medially in the area where the patient has pain. This is from Serazal's article. And then let's go to straight posterior impingement. Posterior impingement is probably the most common of the impingements. And there are a number of causes of posterior impingement. One is a large theata process. You guys have seen this already. You can get ostrigonum. Ostrigonum may be a congenital ossicle, but I believe the vast majority of ostrigonums are actually acquired due to fractures at the base of the theata process. And we've seen a lot of these develop when we've had repetitive MR scans of the ankle. You can get fracture of the lateral tubercle of the talus, which can lead to posterior impingement, prominent posterior tubercle of the tibia, calcified inflammatory tissue, prominent surface of the calcaneus, and prominent tibial slip. So posteriorly, we can have both soft tissue lesions as well as bony lesions as a cause. So basically, the cause can be a large theata process, an ostrigonum. Here's probably a fracture of the theata process with displacement of the fracture, a prominent posterior malleolus, calcified soft tissues, and then prominence to the dorsal aspect of the calcaneus. So common causes of posterior impingement. Tayson, what do you think of this case?
Looks like we have a theata process on this right image here.
So here we can see a theata process here on this sagittal stir sequence. A little bit of edema in it here. If we go to the T1 weighted image, we can see a lot of eburnation here within at least a part of the theata process that we visualized on this one sagittal image. And this was a patient who had symptomatic posterior impingement. The patient also has a little bit of a prominent posterior slip that we'll talk about in a minute. But we can see bone edema at the base of this theata process. This is relatively common, and I think if people continue to exercise after they get these trabecular bone injuries at the base of the theata process, can cause a fracture of the base of the theata process, and I think that's a common cause of ostrigonums. Eventually, then the ostrigonum can kind of heal where it looks more like an ossicle separate from a fracture, and they can actually become somewhat unstable. Here's another example of acute edema within the theata process in someone with posterior symptoms. And this patient who had a kind of acute traumatic injury of the theata process and posterior impingement. Okay. Elior, anything going on in this patient with This patient had posterior ankle pain and limitation of motion.
Um,
John, go ahead.
I'm sorry, my sound keeps coming in and out. The treatment for these is usually the removal of the elongated process.
Okay.
The problem is many times you don't get a cure from it, and then you wind up doing fusions and things of that sort. So it's not an easy problem to treat. This is a very difficult problem.
Okay.
It doesn't look so difficult, but it is.
Thank you. Mhm. Okay. Oleg?
So same thing, just large theater process.
What?
Large theater process.
Okay, sure. All right. So we have a
Same
very
thing.
large stata process, a little bit of edema here at the base of the stata process, but you can see why this patient might have limited range of motion due to impingement from this large stata process. Good. Robert, what do you think of this one?
Here, this one looks like more of a ostrigonum with a little bit of edema and surrounding fluid.
Yeah. And I think this looks like this is probably due to a fracture of the base of the stata process and maybe a loss of fat here, maybe a little osteonecrosis of the fragment, which would be an ostrigonum in this location. A little bit of edema here at this interspace. Again, this can be associated with posterior pain and the symptoms of posterior impingement.
You know, in this situation, you would remove it. You wouldn't fuse it.
Yeah. And here's just a CT scan showing another fracture of the base of the stata process. This is kind of chronic. You've got some eburnation of the bones and some subchondrocystic changes, probably from instability at the non-union of the base of the stata process fracture.
I would be tempted to fuse this.
Okay. And this is what the MR scan looks like, where we can see the edema within the bones on either side, probably from a fracture. We can see some chronic degenerative changes here from hypertrophic bone formation, probably due to posterior impingement from the large stata process, impacting the calcaneus, creating hypertrophic bone formation. And we can also see some bone marrow edema, the posterior malleolus here, also probably from a posterior impingement. Okay. Let's see. Tayson, are you next?
Yeah.
Okay.
So it looks like we have prominent osteophytes from the posterior subtalar joint.
Okay. So here we can see a prominent osteophyte on the calcaneus, stata process here, and probably some eburnation involving the posterior malleolus. This is on a low field scanner, so we don't really have great resolution. We can see some edema at the base of the stata process on the sagittal stir. Another case of posterior impingement.
This is congenital, isn't it, John? This is a congenital problem.
John, I would guess acquired, but it could be congenital. This was an older individual.
Yeah, it just the way the talus is, and it's pointing downward, and
Well, this patient was scanned in plantar flexion. This was in uh, an extremity scanner where you can't have dorsiflexion of the ankle. You have to image just in plantar flexion. So the shape of the talus really has to do with the limitations of the positioning in the scanner rather than the congenital. Yeah. Okay. Let's see. Oleg? So this patient also had posterior ankle pain.
Yeah. So it's a ligament.
Okay, all right.
So
good.
it's a
So that looks pretty good,
pos-
but here it looks like it's thickened.
second ligament. It's a posterior taliofibular. No,
Well, we'll go through that. If we look on the sagittal images, this looks pretty okay. A little bit of irregularity of the posterior there. But if we go across there, you notice that this posterior ligament gets very thickened here. This is actually called the posterior slip. See how big and thickened it is. And right where it's thickened, we have eburnation of the cortex of the steata process here. And this is, and then if we go to the stir images, we can see a little bit of edema within the steata process. Here's that thickened posterior slip coming across. So this is a soft tissue cause. And then here, going a little bit farther over, marked thickening of that posterior slip. So this is a posterior impingement due to a large tibial slip posteriorly. And I think I had, back at the beginning of this, oops. No, I don't. Somewhere I have a diagram of the different ligaments of the posterior ankle, but I don't see it here. So anyway, so this is a soft tissue cause of posterior impingement, which is a large posterior tibial slip. Right here. Okay. So actually, why don't we stop here, and then we'll go into bone trauma, different kinds of bone trauma in the foot and ankle, starting on Monday. Okay.
Have a good weekend, everybody.
Have a good weekend. Thank you.
Yeah.
Thank you.